Hello, people, and welcome to Med Novice, where we make tough medical stuff make sense. Right? So, the topic for today's video is growth adaptations, and basically, we are starting with the pathology section. So, what we need to see here is that under normal homeostatic conditions, on the organs of the body, we have a basic amount of physiologic stress which is present. Right? A basic amount of physiologic stress is present on the organs, and an equilibrium is maintained between these. Now whenever you will change the stress, either you will increase it, either you will decrease it, or you will change the type of stress, right? Whatever changes you bring in the stress, the organ will have to adapt to it, the organ will have to counteract it, and the changes occurring in the growth of the organ, in order to counteract the changes in the stress, is referred to as growth adaptation here. Okay, so now we will be coming to our first growth adaptation. We will be discussing hypertrophy and hyperplasia together. Hypertrophy and hyperplasia. Okay, so what happens here is that there is an increase in stress which leads to increase in the organ size, right? Now if you want to increase the organ size, it can occur in two ways, right? Either you can increase the cell size, or you can increase the cell number. Now to increase the cell size, what you will have to do, first of all, you will have to build the skeleton on which this increased size of cell will be stable on, right? So first of all, you will have to increase the cytoskeleton in the cell in order to provide that framework for the extra part you are forming just to counteract the stress, right? So you need to increase the cytoskeleton, which means you need to increase the cytoskeletal elements. And what are they? They are proteins. So if you want to increase the proteins, what you will have to do is you will have to increase protein synthesis, for which you will have to ultimately do gene activation, right? So gene activation will lead to increased protein synthesis, due to which we will have more cytoskeletal elements, and hence we will have the framework for the extra part of cell that needs to be built in order to counteract the stress, the increase in stress that is occurring in that situation. The second thing what you can do is you have to increase the number of organelles in the cell, right? So these are the two ways by which you can increase the cell size. And whenever you increase the cell size, this is referred to as hypertrophy. So this is hypertrophy. Now if you want to increase the cell number, right, so for that what you will have to do is you will have to produce new cells from stem cells. You need to produce new cells from stem cells, right? And whenever you increase the cell number, this is referred to as hyperplasia. Okay. So what we have discussed yet is that whenever there is increase in stress, in case of hypertrophy and hyperplasia, there is an increase in organ size. And how that can occur? That can occur either by hypertrophy, which is increase in the cell size, or it can occur by hyperplasia, which is increase in the cell number. Okay. Now to increase the cell size, what you can do is you will activate the gene. You will activate the gene which will lead to increased protein synthesis. You will have more proteins, and hence you will be building more of cytoskeleton, which will provide a framework for that extra part of cell that you need to build to counteract the increase in stress, right? Second thing what you will have to do is you will have to increase the number of organelles. Now talking about increasing the organ size by increasing the cell number, this is referred to as hyperplasia, right? And in hyperplasia, what you will have to do is you will have to produce new cells from stem cells. Okay. Now usually these two processes occur together. Like for example, you can discuss about the uterus during pregnancy, in which you will see that both hypertrophy and hyperplasia are taking place hand in hand, right? But now let's discuss about permanent tissues. What's the case here? in case of permanent tissues, we don't have stem cells, right? There are no stem cells, or and the cells of the tissue, they don't have the capability to divide. Hence, what you can say is hyperplasia is not possible in them, right? So hyperplasia is not possible in case of permanent tissues. Hence, permanent tissues will undergo hypertrophy only when required, right? Hyperplasia is not possible in permanent tissues. Usually these two processes occur together, but in permanent tissues, hyperplasia is not possible. Hence, hypertrophy is the only way to counteract this increased stress, right? Now, talking about another thing, that is pathologic hyperplasia. So, pathologic hyperplasia is when you have the increase in the stress due to some pathological condition, and which is being counteracted by hyperplasia, and this thing can lead or progress to dysplasia and cancer, right? This can progress to dysplasia and cancer. Now, a basic, a general note coming down here is that in any of the growth adaptation where you see that cell division is occurring, right? If that cell division goes unregulated, then in any of these growth adaptations, wherever cell division is taking place, you can see that it may progress to dysplasia and cancer, right? If the proliferation of the cells goes unchecked, in that case, you will see that there might be a progression to dysplasia and cancer. So hence, if we have a pathologic hyperplasia, it can progress to dysplasia and cancer, right? Because in hyperplasia, what we were doing was we were making new cells from the stem cell, which obviously required division, and if this division goes unchecked, unregulated, it will easily progress to dysplasia and cancer. But there is a case of pathologic hyperplasia which doesn't progress to dysplasia and cancer, and that is benign prostatic hyperplasia. So this is the case where this pathologic hyperplasia doesn't progress to dysplasia or cancer, right? And if you want to discuss a general example of pathologic hyperplasia which can progress, then you can discuss about endometrial hyperplasia, which occurs due to overexposure to estrogen. With this, we conclude our first growth adaptation, and now we will move to the second one, that is atrophy. Okay. So what happens in atrophy is, before we discussed, there was a increase in stress which led to increase in the organ size, but in atrophy we have decrease in stress which will lead to decrease in organ size. Now again, how will you decrease the organ size? Either you can decrease the cell size, right, or you can decrease the cell number. Now, to decrease the cell number, you will have to kill the cells, and that is known as apoptosis, programmed cell death, right? So apoptosis is the way to decrease the cell number. And now talking about decreasing the cell size, what can happen here? When we had to increase the cell size, we had to build the extra framework, right? Now when you have to decrease the cell size, then you have to obviously decrease the cytoskeleton. Some of the framework, the extra framework, needs to be removed, right? And how does this occur? This occurs by ubiquitin proteasome degradation. This occurs by ubiquitin proteasome degradation, right? What happens in ubiquitin proteasome degradation is, let's say you have a intermediate filament, right, and you want to degrade it basically. So what you will do is you tag it with ubiquitin, proteasome comes, and it identifies the molecules present within the intermediate filament which are tagged with ubiquitin, and it degrades those molecules, right? So this is how ubiquitin proteasome degradation works to decrease the cytoskeleton. Other way to decrease the cell size is that you can fuse the autophagic vacuoles with the lysosomes, right? So the other way to decrease the cell size is autophagy of cellular components. Autophagy of cellular components, right? And how will that occur? Basically, there will be fusion of autophagic vacuoles with the lysosomes. So with this we complete atrophy, and now we will move to the third and quite important growth adaptation, which is metaplasia. What happens in metaplasia is there is a change in stress, and to counteract this change in stress, the organ doesn't increase in size or decrease in size. Instead, what it prefers is to change the cell type, right? So whenever you see that there is a change in stress and it is being counteracted by a change in cell type, you will say that metaplasia has happened here, right? So metaplasia is something which most commonly involves surface epithelium. It doesn't always involve surface epithelium or only involve surface epithelium. There can be mesenchymal tissue, we will see ahead, which can undergo metaplasia in response to the change in stress. But most commonly, surface epithelium is involved. Now, why we have changed the cell type? It is obvious that the previous cell type would not have been able to handle the stress in that good manner, right? Yeah. So what we need to understand here is that we have changed the cell type, which means the previous cell type would not have been able to handle that stress in a better manner, right? So metaplastic cells are better able to handle the stress, hence we have changed the cell type. Now coming to the example of metaplasia, quite common and quite famous example, is Barrett's esophagus. Barrett's esophagus, right? So let's say you have a patient with GERD, gastroesophageal reflux disorder, right? So what will happen is there will be acid reflux into the lower portion of esophagus, right? And due to that acid reflux, the normal squamous epithelium which is present here will be exposed to acid, so there is a change in stress, right? But the question is, are squamous epithelial cells able to handle that stress? The answer is no, right? So now they will have to undergo metaplasia, and what they do is they convert into non-ciliated mucinous columnar epithelium. They convert into non-ciliated mucinous columnar epithelium. Now why it is mucinous? Obviously because if mucus will be there, it will protect the lower esophageal lining from corrosion, right? So the squamous epithelium changes into non-ciliated mucinous columnar epithelium, and this is Barrett's esophagus. And how does this occur? Now basically you will have to reprogram the stem cell. So there is reprogramming of the stem cell in metaplasia in order to change the cell type. Another important thing is that if you remove the driving stressor, in that case metaplasia is reversible. Right. For example, if you treat GERD in this case, there will be reversal of Barrett's esophagus. This is one point that metaplasia is reversible. Another point that we have to discuss is that again you see there is reprogramming of stem cell, right? So again from stem cell you will be producing the new type of cell which you are selecting in order to handle the stress in a better manner, right? So there will be proliferation of cells, there will be division of cells, right? And wherever I said in any growth adaptation you see the division of cell is occurring, there is a fair chance that if the division in cells goes unregulated or unchecked, then it may progress to dysplasia and cancer, right? So what we can conclude is that metaplasia can lead to can progress to dysplasia and cancer, right? So this can happen. For example, if you talk about Barrett's esophagus, so it can progress to adenocarcinoma of the lower esophagus, right? But there is an exception to this statement. There is an exception where metaplasia cannot progress to dysplasia and cancer. And what exactly is that exception? So in case of fibrocystic changes, of breast, what happens in the terminal ducts is that you see the normal cuboidal epithelium, right? Normal cuboidal epithelium, it converts into apocrine cells, right? So in case of fibrocystic changes of breast, we see the normal cuboidal epithelium converting into apocrine cells, and this is an exception. This is an example of metaplasia, known as apocrine metaplasia, which does not progress to dysplasia and cancer, right? So this is one thing. Now, to understand what exactly do we mean by apocrine cells, right? What exactly do we mean by apocrine cells? So if you remember, we had three types of glands. And they were merocrine, right? In merocrine gland, what we used to see is that the secretory product was released by exocytosis of the secretory vesicle, right? And the example for merocrine gland was salivary gland. Lovely. Now talking about the next type is apocrine gland. In apocrine gland, what we used to see is that there was not a secretory vesicle. Instead, what happened was that the apical part of the cell, right? Let's say this is the cell. The apical portion used to be pinched off with the secretory product, right? So this was the apocrine gland, and its example, you can say sweat glands, and also the mammary glands. Right, sweat glands and the mammary glands. These were examples to apocrine type of gland. The third type is holocrine. So in case of holocrine glands, what happened was the entire cell disintegrated to release the content, right? And the example to this is sebaceous gland. So this is from where we are talking about apocrine cells. Now let's come to the diagram, right, of what and all things we have discussed here. See, here you can clearly see that the normal breast ductal cells were of the cuboidal type, right? But now they have this apical tufts, right? These are the way you characterize the apocrine cells, and hence you can say that the normal cuboidal epithelium has converted into apocrine cells, and this is apocrine metaplasia, and this is an example of the metaplasia which won't progress to dysplasia and cancer. Second thing what we can see is Barrett's esophagus, right? So here you can see that you have the squamous epithelium from, let's say, the part just above the lower esophagus, and here metaplasia has occurred. Acid exposure would have been here, and hence the stem cells reprogrammed. What you can see is this these mucinous vesicles, right? And these columnar cells with the basal nucleus. So this is what we were referring to in Barrett's esophagus. This is how it looks, right? You have mucinous vesicles within the cell, and the cell type has changed from squamous to non-ciliated mucinous columnar epithelium, right? So this is Barrett's esophagus. Now moving to another point, we will have some discussions about vitamin A, right? Now vitamin A, two important roles, what you can discuss is it helps in development of immune cells, right? B cells, the T cells. Um, Vitamin A helps in development of B cells and T cells. Okay. The second thing what it does is it protects the specialized epithelia. The specialized epithelia present in your body, right? For example, a specialized epithelia is present in your eyes, and that is basically conjunctiva, right? And if there is a vitamin A deficiency, then that protection is not there, due to which the cells will undergo change to counteract the stress, and hence what will be the result? You will see keratomalacia, right? So this can occur due to vitamin A deficiency, leading to metaplastic changes, leading to keratomalacia finally. Now, another thing what we will be discussing here is that vitamin A helps in development of immune cells, and in case that there is a translocation of the 15th and 17th chromosome, there is a translocation between the 15th and 17th chromosome. In that case, what you can see is that the vitamin A receptors, the retinoic acid receptors, are disrupted, right? They are disrupted, and the retinoic acid receptors, as they are disrupted, they hinder the development of immune cells, and you are unable to form proper B cells and T cells, right? Now, to treat this, what we do is basically here the cells remain in blast stage, as they are not able to develop into B cells and T cells. And another thing, this is seen in acute promyelocytic leukemia. What happens is, to treat this condition, we give all trans retinoic acid, which can bring out some conformational changes in this disrupted retinoic acid receptor, and due to which it can, what you can say is, facilitate the binding of retinoic acid with these receptors, right? And hence which will treat this underlying cause and lead to development of proper immune cells. So this was one point related to vitamin A. Regarding metaplasia, you had to remember this thing, right? That vitamin A protects specialized epithelia, and its deficiency will lead to metaplastic changes, and that can result into keratomalacia, right? And the other point was just to discuss about vitamin A. Okay. Now these are the changes we discussed in surface epithelia, but we know that mesenchymal tissues can also undergo metaplasia, right? For example, you have myositis ossificans, right? Myositis ossificans. What happens here is that you have trauma, let's say, and trauma results into inflammation of the skeletal muscle, right? Now, as there is inflammation of the skeletal muscle, obviously there is an increased stress, right? And as there is increased stress, while healing, we will see that metaplasia has occurred in order to counteract that increased stress, due to which what you will see is that some ossification occurs, or some amount of bony mass grows or develops within the muscles, right? So let's see the diagram. Basically, you will understand it better on the X-ray. So this is the bone, okay? This is the bone, and surrounding it is the muscle tissue, right? So a trauma would have occurred, or there would have been the inflammation of the muscle, right? And what you can see is that during healing, there is some bony mass which has grown here in the muscle, right? So this is referred to as myositis ossificans, and it is occurring due to metaplasia during the healing, in response to the increased stress due to inflammation of skeletal muscle, which can occur due to trauma or due to some other reason, right? So this is myositis ossificans. And another important discussion what we have here is to differentiate myositis ossificans from osteosarcoma, right? So what you can see here is that the bony growth is within the muscle, it isn't involving the bone. You can't see any lytic lesions on the bone, right, or any eaten off part on the surface of bone. The bone surface is quite regular. But in case of osteosarcoma, which is a type of cancer, right, the bone is involved directly. Hence, what happens is this cancer arises from the bone, right? This is the diagram. This is the X-ray for osteosarcoma. So what you can see here is that the bone surface has been involved and a classic sunburst appearance is there. A classic sunburst appearance is there, right? So this helps to differentiate on the X-ray osteosarcoma from myositis ossificans. In myositis ossificans, you will see some bony growth in the muscle tissue, right? And it won't be involving the bone, or it won't be disrupting the surface of the bone. But as in case of osteosarcoma, the sarcoma is originating from the bone itself. It will obviously disrupt the regular surface of the bone, and what you will see is a classic sunburst appearance on the X-ray. So this is how you differentiate myositis ossificans and osteosarcoma. And another thing, myositis ossificans is an example where you can see that mesenchymal tissue is undergoing metaplasia, right? So with this we conclude metaplasia, and now we will move to some other associated topics, not exactly growth adaptations. So the first one what we will be discussing is dysplasia. Dysplasia, if you break this word, it is dis is for disordered and plasia is referring to the cell growth. So if there is disordered cell growth, right, that is referred to as dysplasia. What do you mean by it? Dysplasia in simple terms refers to the proliferation of precancerous cells, right? Proliferation of precancerous cells, which you can see in the case of CIN, let's say, which is cervical intraepithelial neoplasia, right? So in that case, you can see there is proliferation of precancerous cells. We will be discussing it in detail when we will be discussing the female genital system pathology, and this is a case where you can see dysplasia occurring. Another thing to discuss here is that any growth adaptation, again, we saw, which involves cell division, if goes unchecked, may progress to dysplasia and then further progressing to cancer, right? So dysplasia is reversible, but cancer is not. Cancer is not reversible, but dysplasia is reversible, right? And dysplasia usually arises from long-standing pathologic hyperplasia or metaplasia. Okay, these were the two main growth adaptations which we saw involved cell division. Okay, and if the stress persists, then dysplasia may progress to cancer. If the stress is removed, then as dysplasia is reversible, you can come back to the normal circumstances, right? So this was a small commentary on dysplasia, and now we will be discussing the fifth type, that is aplasia, right? A will be referring to absent and plasia is cell growth. So if the cell growth is absent, right, there is failure in the cell growth when it occurs during embryogenesis, right? So if there is failure in cell growth during embryogenesis, that is referred to as aplasia. And what will happen if the cell is not growing? You will ultimately result in loss of the organ which this cell was going to make, right? For example, you can see unilateral renal agenesis. So in case of unilateral renal agenesis, what happens is that one side your kidney has not formed. Why? Because there was aplasia, which is failure of the cell growth, and this occurs during the embryogenesis. Now the sixth topic and the final topic which we will be discussing is hypoplasia. So during the embryogenesis, what can happen is when you can have failed cell growth, right? Other thing what you can see is there is cell growth, but there is a decrease in cell production, right? There's a decrease in cell production during embryogenesis, which results in a small organ. So in case of aplasia, there was failure of cell growth, due to which there was the organ was absent basically. While in hypoplasia, there is a reduced cell production, due to which the organ which is being formed is comparatively small as compared to the normal size, right? So what is the example for hypoplasia? The example is streak ovary in Turner syndrome, right? Turner syndrome is 45 plus XO, right? Only one sex chromosome is present, and that is the X chromosome, and this occurs in females. And there you see the streak ovary, which is a small ovary, which is due to the reduced cell production, right? With this, we conclude our discussion on growth adaptations. I hope you liked the video. I hope it was helpful for you. And if you want more of such content, I request you guys to like, to comment on the video, and to share the channel with your friends, to share the video with your friends. With this, we conclude the discussion. Thank you guys. See you next time.